My name is Michael Piccione. I am a veterinary diagnostician here at TVMDL, the Texas A&M Veterinary Medical Diagnostic Lab. And I appreciate everybody here joining today. Good afternoon to those Central Time and Eastern Time, or good morning, depending on where you're calling from. But today we're going to talk about canine and feline urolithiasis. A brief overview for today. I like to set the stage of what you're in for. We'll start off by talking about an introduction to urolithiasis and what uroliths are. How do we define them? How do we define this condition? From there, we'll talk a little bit more about formation, so the pathophysiology on how these stones come to be. We will talk about some very common stone types. I will just say it won't be every stone type under the sun, but many that you'll encounter here in clinical practice. From there, we'll talk about clinical signs. So what do these patients, whether dog or cat, manifest with? And we will talk more about diagnoses. And in regards to diagnostic testing that's available, one thing that we will really try to showcase a little bit is FTIR. And then finally, we'll round out this presentation with a focus on treatment and prevention. So first of all, with definitions, I like to set the stage and just say, for the purpose of this presentation, uroliths are essentially urinary stones. They're calculi. You're going to hear me use those terms interchangeably. I like to say that because I tend to use these terms all the time, and I don't want there to be any confusion, especially when we talk about something foundational like this. I do also want to make a note, and a lot of this may be common sense, but I do want to mention crystals are going to be the building blocks from which all these uroliths are going to be forming. And so the two are not necessarily synonymous, but I do want to make it known because I think this will be very important in regards to a diagnostic standpoint, but also a treatment and prevention, which we'll dive into here a little bit later. Urolithiasis itself is a condition where calculi form within the urinary tract. And I say this because urinary tract is not just limited to the bladder. I will tell you just from experience, I have seen diagnostics run where, we get tunnel vision and we say, if there's uroliths, they've got to be in the bladder. And we take an image and there's nothing there, but then sometimes we get fooled. So please keep in mind that uroliths can form anywhere in that urinary tract. That may be the kidneys, that may be the ureters, it can be anywhere. So make sure when you are trying to image these patients that you include the entire tract itself. Finally, I do want to mention this concept of supersaturation. It's an important one because many of the uroliths that we encounter in our patients are going to be associated with concentrated urine. And common sense says that sounds about right, but I really like to dive into the whys. And so for me, what's important is that these crystals are going to form when there is more dissolved minerals than the urine itself can handle. And so the likelihood of a patient developing a urolith is not only dependent on the amount of minerals present, but also the volume in which they're dissolved in. And so when that urine becomes supersaturated with a particular mineral, whatever that may be, that's when you're going to start to have problems. And I feel that concept is really fundamental, not only from a treatment standpoint, but also from a prevention of disease standpoint. So please keep that in mind. So the anatomy of urolith, I think one of the things that fascinates me most about uroliths is that none are created equal. No matter how many you see, there may be certain criteria that some of these fit into, but nonetheless, none are created equal. And there are a lot more to these stones than meets the eye, which I think this picture showcases really well. This I took from the University of Minnesota website, a great resource. But for the purpose of this presentation, I do want to focus on two particular aspects of this anatomy. The first is going to be the nidus. For me, this is where it all starts. And for all of us, this is going to be where it starts. And the reason why that's important is because this is really going to be an area of focus, not only for treatment, but also prevention. You'll hear me talk about in this presentation a lot of these uroliths forming as a result of mineral changes. Please keep in mind that the nidus for some of these uroliths may not be a mineral. It could be protein. It could be a blood clot. It could also be things like suture. So if you do have these recurrent offenders and surgery is required, please keep in mind to cover your bases by ensuring that you're not predisposing this patient to something, therefore, in the future, meaning recurrence of the urolith itself. The other aspect of this anatomy that I like to discuss or at least mention is the shell. I think this is important, again, for a treatment aspect of it. We have to know the composition of the urolith, but uroliths are not necessarily homogeneous. The shell of the urolith may not be the same as what the core of the urolith is. And I say that because many patients may have, or some may have, multiple underlying diseases. You could have a patient, in this case I mentioned on here, a portosystemic shunt and a urinary tract infection. And so if you are working this patient up and you do a urinalysis and you see not only does this patient have the symptoms, but this patient also has diagnostic signs, images show stones, urinalysis shows crystalluria of struvites, you cannot assume that the uroliths in the bladder are all struvites. There may be some composition. In fact, if the sediment is loaded with struvite crystals, there's likely a component there. But be mindful that if you treat this underlying struvite issue and 2 months, 3 months later, this dog is still manifesting, or cat is still manifesting with urolithiasis, there is likely something else contributing to that particular case. So keep that in mind. Common uroliths. So let's segue. So we've already talked about many of how these uroliths form. Let's talk about what you're going to encounter in clinical practice in regards to your canine and feline companions. And the first that we talk about, or that at least I want to talk about, is going to be your struvite crystals, or your struvite stones. So these stones themselves are composed primarily of phosphate, ammonium, and magnesium. And again, all of this is going to be very important from a fundamental or foundational standpoint to help you remember how treatment looks like, or what prevention looks like in some cases. You will hear these stones referred to as triple phosphate. Please keep in mind, as I just mentioned seconds ago, there is a lot more to these uroliths than just phosphates. Don't be misled. These particular stones do favor alkaline urine. I also like to say, for this entire presentation, please keep in mind when we talk about things like pH changes or signalments, it's not a one-size-fits-all. You may run into an exception to the rule, but some of these tips and hints may help you diagnose these patients that much quicker, treat or prevent that much quicker. In regards to signalment, again, these stones can manifest in canines or felines. Some of your canine breeds that you're going to run into, not all including, but miniature schnauzers, Pekingese, Lhassos, these tend to be your smaller breeds in general. Middle-aged females tend to be overrepresented. Many times the question comes up, well, why? In this case, I like to focus on urinary tract infections. And then the question is, well, why are urinary tract infections so important? Well, the simple answer is urease producing bacteria. And so urease, a quick chemistry lesson, urease splits urea into ammonia. And this ammonia, when it's in the urine, acts as a weak base and can bind hydrogen ions to form ammonium. And that reaction is important for the obvious sense that ammonium is going to be one of the building blocks for these uroliths, but it's also important because it explains why there is a subsequent increase in pH. And we just talked about a second ago, that increase in pH indicates that alkaline urine. Interestingly enough, for our feline friends, and I'll admit I'm a cat person myself, cats don't always read the book, and struvite uroliths are no exception. So while cats with struvites can have urinary tract infections, it does not always mean that they're going to. So you can have a cat without a urinary tract infection that still has struvite uroliths. So be mindful there. But there are other concerns or reasons for formation. That may be changes in pH, whether it be for a concern with altered levels of proteins. There could also be issues with altered levels of magnesium, and other factors just in general. Maybe this patient's not drinking enough. Maybe they have chronically elevated urine concentrations, for whatever it may be. All these factors can add up. And like I mentioned a second ago with our cats, with dogs, they don't necessarily have to have a urinary tract infection. Again, these are just some signs that may lead you to believe that there is a urolith concern or a struvite concern specifically. Next up, we have calcium oxalate. So calcium oxalates, thankfully, unlike struvites, they're pretty straightforward. They're formed from calcium and oxalate. There's no hidden concern there. Unlike struvites, they do tend to form at more acidic pH. However, they can form at neutral pHs. So just be wary that you may not have a pH imbalance. It may be neutral, and you can still have these calcium oxalate stones that form. When we talk about signalment, we are seeing this more commonly, again, in our middle-aged older patients, whether it be dog or cat. Some of the commonly affected breeds may be Yorkies, Shih Tzus. For cats, it may be Persians, Himalayans, Burmese. Again, even though your patient may not be one of these breeds, they can still form these particular uroliths. One of the things that I do like to highlight here with calcium oxalates is one of the big factors, aside from diet, aside from water intake, are disease states. And in fact, you may commonly see these more associated with disease states. In dogs, one of the things that I like to highlight is parahyperparathyroidism, and in cats, hypercalcemia of malignancy. A brief endocrine lesson, very quickly, is that hyperparathyroidism causes excess parathyroid hormone. And the reason why that's important is because in turn, this leads to this increase in bone resorption, which causes an increase in blood calcium levels. In addition to that, though, it also causes increased calcium absorption in the intestines via calcitriol, and finally, increased calcium reabsorption from the renal tubules back into the blood. And for many, you could say that last part is, well, that's a great thing. These uroliths are forming in the urinary tract. The kidneys are doing their thing. They want to pour it back into the blood. That's a plus for the urinary tract. The dilemma here, and while it sounds great in theory, is that these kidneys do get overwhelmed. And when these levels of calcium are too much for them to keep up with, that's when you're going to start to have problems, when that capacity is exceeded. The urine itself then reaches this supersaturated state, which we talked about a few slides ago. And like we discussed before, when you find yourself or the patient's body is in that supersaturated state, specifically in that urinary tract, that is going to be the foundation for this crystal formation and thus urolith formation in general. Regarding patients with hypercalcemia malignancy, some of these patients have these tumors that secrete this parathyroid hormone related peptide, or PTHrP. Those act very similar to PTH, and thus you have a very similar process like the one we just spoke about, hence why those patients are predisposed and can develop the calcium oxalate uroliths. Next up, we have cystine. So cystine uroliths are going to be one of the more rare uroliths that you encounter, but nonetheless, you will come across one from time to time. I do like to talk about what is cystine. It's a sulfur-bound or multiple sulfur-bound cysteines. Those are amino acids. And so the primary source of these amino acids are through diet, specifically protein, which is why, as we'll talk about later, diets can be point of concerns for many of these particular patients. I like to talk about trends. With cystine uroliths, they do tend to favor acidic pH, much like our calcium oxalates that we talked about a second ago. In terms of signalment, you do tend to see males overrepresented here, And some of these breeds, again, including but not limited to Newfoundlands, English Bulldogs. For our feline friends, again, they don't typically read the book on some of these things. There is no strong breed predisposition for our feline friends. What I do like to highlight here about cystine uroliths is a particular defect in the renal tubular transporter protein. And so the question really is, what is going on with these particular patients? Why are they predisposed to cystine uroliths? Well, essentially, there is a defect in a few genes. One is called an SLC3A1, and another is called an SLC7A9. So these genes are responsible for coding an amino acid transporter, which we just talked about. Those amino acid transporters are responsible for reabsorbing cysteine. So as you can imagine, if you have a defect in that coding, those amino acid transporters don't work as efficiently as possible. And unfortunately, these transporters primarily work in the proximal renal tubules. So again, as you can imagine, when there's a lack of reabsorption, what happens? The cysteine molecules accumulate in the urine. They exceed that saturation threshold in the urine. And then again, these are the patients that are going to start to develop these crystals and inevitably uroliths. I do have on here that there are various types of these particular carriers. The question arises, well, what is that all about? Why is that relevant? There is a link between androgens and canine cases for cystine uroliths. And the link there, or that exact mechanism, I will argue is still debatable. But the point is there is a very strong connection between intact males and the formation of these uroliths. And the reason why this is important, and the reason why I bring this back to the type 1 through 3, some of these carriers of type 1, type 2, and type 3 are more dependent on various androgens, type 3 being thought as the most androgen dependent. So you can still neuter these patients, and it may not have the desired effect. There was a great paper that was released last year by Dr. Lulich and JVIM that showed a vast majority of these patients in this particular paper that were diagnosed with cystine uroliths. They were intact males. And then another paper from Dr. Larson kind of followed up with that notion and really talked about a significant decrease, this finding, I should say, of the significant decrease in cysteine excretion in dogs after neutering. So there's definitely this correlation here. While the exact mechanism, like I said, is still debatable, it is a very fascinating concept and something you should consider when treating as well as preventing these uroliths long-term. Next up, ammonium urates. To explain ammonium urates in general and how these stones are formed, I do want to give yet another chemistry overview and talk about not only how they're formed, but what normal looks like in these particular patients. So first off, what are purines? Essentially, they are nitrogen-containing compounds. And this is important because these will be the building blocks for ammonium urates. So purines themselves help form nucleotides, adenine, guanine. Basically, they help form DNA and RNA. For our purposes as veterinarians, we should be concerned because they are commonly found in organ-rich meats. So not muscle meat like thigh, like we typically think about with chicken or something like that. We're talking specifically organ-rich meat. So your patient is either consuming this in their diet, these purines, or they are making them as a normal byproduct of cell death. It is the former, however, that we really focus on from a development standpoint and a treatment standpoint. So what happens? I keep talking about purines. Why are purines relevant? So purines in a normal patient are processed through a very extensive metabolic pathway, and eventually they're converted to uric acid. And finally, allantonin. All of this occurs, though, within the liver. There is a gene, however, this SLC289, that encodes this transporter protein, yet another transporter protein, unlike the one we talked about. This transporter protein is not only responsible, though, for transportation of uric acid in the liver, but also uric acid in the renal tubules. And so when this transporter doesn't work appropriately, you ultimately have an increase in uric acid accumulation in the body. And rather than it being reabsorbed from these tubules, so again, the tubules are trying to keep up, pushing this back into a more equilibrium state, they lose sight of that. They're not able to keep up, and this uric acid stays in the urine itself, leading to a condition that you are probably aware of, or at least have heard of this hyperuricosuriasia. It's a fancy term for a lot of uric acid in the urine. And that uric acid is going to be the formation for part of that ammonium urate. The ammonium component here in the urine already is able to combine with that uric acid, and that's how you have this formation of this ammonium urate crystal. I mentioned on this slide here about Dalmatians and Bulldogs, fixed versus not fixed, and what is it all about? You'll notice simply here, it is thought of that most, I won't say all, I have to be very careful, but most of these purebred Dalmatians are homozygous recessive for this particular gene. And homozygous recessive states are the ones that have this defect in this gene for this transporter protein. Now, this has changed in recent years. There's a lot of discussions and support from basically breeding Dalmatians with pointers to help kind of dilute out this state. But nonetheless, much of your purebred Dalmatian population are going to be homozygous recessive for this defect. So if you see a Dalmatian, you want to be on guard, or maybe at least educating your clients about this particular condition. English Bulldogs, however, and some of these other breeds, they're only carriers, meaning they may be homozygous dominant or they may be heterozygous. Not all of them are going to manifest with the disease like our Dalmatians, or like most of our Dalmatians will. I do also want to say, and I skipped over it briefly, but this carrier gene issue is more a problem in our canines, not so much a feline concern. Our felines, though, can be affected, much like our dogs, our canine companions, through portosystemic shunts and also liver disease. So with portosystemic shunts, the story is a little bit different. They have a problem not only with uric acid, but also ammonium. Because blood bypasses the liver, that conversion of uric acid can't take place as appropriately as possible. This leads to that excess amounts of uric acid, ammonium, and concurrently all of this builds this perfect storm for ammonium urate formation. Clinical signs. So far we've talked about how these uroliths are formed. We've talked about some common uroliths that you're going to encounter in practice, but how do you identify these patients? How do you know that one walking through your door at any given time is going to have a urolith? Well, the short answer is you don't, right? That is one of the most difficult things about our profession, is that we can't talk to these patients. They can't tell us, oh, I have all this abdominal pain today, and oh man, I'm not urinating quite great. We rely on what we find on physical exam, we rely on our diagnostics, and we rely a lot on clinical history from that owner. So some of these patients that you're obviously going to be more wary of are those manifesting with things like hematuria, or painful urination, straining to urinate, maybe urinating more frequently. Those can be more the common signs that may just jump out at you. But unfortunately, as we go down this list, you may have some not so common findings, or maybe things that you wouldn't expect that can throw you for a loop, like abdominal pain, or things like nausea, inappetence, lethargy, or my personal favorite is when they're asymptomatic. I tend to be a big advocate for preventative care and preventative care medicine, much like I'm sure all of us are here on this call today. But with some of these patients, they come in for a routine checkup, right? They're here for their routine visits, and you happen to be doing a urinalysis, and lo and behold, there's struvites everywhere, and you're like, oh my gosh, what is going on? The owner says no clinical findings at home. You're talking to this client, and this patient is just generally asymptomatic. And I have encountered that many times, as have my colleagues, especially when we get these patients. We tend to just be taking routine imaging just to make sure everything's looking great. And lo and behold, we find these uroliths in the bladder, and you kind of look like the hero in those cases because clients were unaware, and you've potentially saved this patient from a lot of headache, a lot of unnecessary pain, a lot of discomfort, and overall a quicker, recovery and a quicker return to a great quality of life, all by finding this thing preventatively. So let's talk a little bit about diagnosis. So we have clinical signs, but how are we going to diagnose these patients? How are we going to know for sure that these patients have a urolith? Well, thankfully, we have a lot of diagnostic tools. The first of which is a urinalysis. Many of the things that you should be looking on a urinalysis can help you determine whether or not a patient either has a urolith or, more appropriately or indirectly, has the foundation for urolith formation, one of which includes pH. We talked about earlier some trends in pHs and what that can mean for certain stone formations. Also, urine-specific gravity. When I talk about urine-specific gravity, we have to be very careful because many of these patients that are forming them have very concentrated urines, and we talk again about that supersaturated state. Finally, sediment findings, and I have some pictures here to show you all with some struvites, some calcium oxalates. These are all findings that you may see on sediment that may lead you to believe that there's a much bigger problem going on. I also mentioned urine culture here, not necessarily for a direct correlation between that and, say, a urolith, but if you have a urine culture and you find that there are bacteria on there that are producing urease, and you have this chronic UTI issue in these patients and chronic issues with hematuria, start to be thinking about a bigger picture. Is there another underlying issue that is at hand? Next up, we have imaging. This may be the biggest slam dunk you have in your hospital, and maybe you just have radiographs, maybe you have ultrasound, maybe you have both. But regardless, each of these tools can be used to help see the actual stones themselves. In regards to urates and cysteines here, I throw this little blurb on here. These are uroliths that radiographically are not going to be as prominent on images than, say, things like struvites and calcium oxalates. That's not to say you can't see them, but more importantly, if you don't see them, you may not be able to rule out those particular uroliths. In regards to CBC's chemistries, I think these are very helpful for those patients with other underlying disease states. Specifically, if we have patients with decreased BUN and cholesterol, and they have this signalment, potentially they have a portosystemic shunt. Or we talked about earlier with calcium oxalate patients, these patients with this chronic hypercalcemia. Those are some tools that you can use at your disposal that will maybe help you paint a much larger picture of something that could be transpiring underneath the surface. Finally, we have another tool at our disposal. And when I say at our disposal here, that we offer at TVMDL, and that is going to be FTIR. FTIR stands for Fourier Transform Infrared Spectroscopy. And like I said a second ago, this is a technique that we have here at TVMDL to identify urolith composition. I do want to note that this is not the only way to identify urolith compositions. There are other methods out there, but FTIR has established itself over the years as one of the superior methods of identification. Again, it's what we use here. It's what other diagnostic labs use as well. Essentially, how does this instrument work? How does this technique work? Well, it uses infrared light, and kind of a throwback to a physics lesson this time. All objects either absorb light or reflect light. Well, we can use this data. This instrument throws this infrared light at the sample, in this case being the urolith. It gathers all this data, and it uses a program that applies the Fourier transform. And this is actually an operation. It's not the operation in the classical sense of us, you or I, doing an actual procedure. This is a mathematical operation. This was something created by a gentleman a few hundred years ago, Jean-Baptiste Joseph Fourier. He created this mathematical operation, and it's because of that that we're able to use all this data to create a spectrum. The spectrum is a fingerprint of that sample. It is very unique to that sample. And once we get that fingerprint, we can then compare that to a database of known samples to identify the composition. And I'll show you on this particular slide, number one, what our FTIR looks like here that we use at TVMDL. And this is kind of a brief overview of how the physics and how the chemistry works, I guess I'll say, on these FTIR and just kind of the fascinating works of it. So very interesting things. When we see these particular graphs, this is what we get in our diagnostic lab. So here the x-axis represents the frequency of light that interacts with the sample itself, and the y-axis represents how well the sample absorbs or reflects light. And you'll get this very pretty graph. But what I like to showcase is that struvites have a very unique digital, or not digital, but fingerprint than our calcium oxalate. So a very different graph here. And we'll compare that again to another common stone we talked about before, cysteine. And finally, our ammonium urates. And you can see these graphs vary tremendously. And it's important here that when we get these this data in our hands, it doesn't necessarily mean that every urolith that you get in clinic is going to be 100% composition of ammonium urates or struvites. This instrument allows us, along with this program, allows us to help determine a composition ratio to help you in your clinic provide appropriate treatment and thus prevention options down the road. So speaking of treatment, it's a great segue. So the first thing that I want to preface with this slide is basically letting you know that a lot of this data is from the ACVIM consensus recommendations on treatment and prevention of uroliths. And according to that statement, some of the uroliths that you encounter should be medically dissolved. That's a big part of how our diets work or why our diets are relevant. There are a number of out there now. We will talk about some of these throughout the subsequent slides, but I do want to take a moment to discuss basically how these diets work. There's nothing per se magical about them. It's not magic. There's actual science that goes into it. And in general, what these diets do is they work by altering urine pH. So in the case of patients with struvite uroliths, they work by lowering the pH or acidifying the urine. They also work by basically monitoring, or I don't want to use the term minimizing, but modifying more appropriately the building blocks for which these uroliths form. So I mentioned struvites before. They're going to have modified levels of magnesium and phosphorus. All of these diets work to help, in some cases, treat in regards to pH, but some of them also work in regards to prevention by ensuring that there isn't an increase in a particular mineral that's going to predispose them down the road after you've already resolved the issue at hand. This consensus statement also goes into a little bit more about talking points, not only for treatment of upper urinary tract uroliths, but also lower urinary tract uroliths. And that's very important because treatment for them will be naturally very different. Another thing that I really appreciate this publication for is the prevention aspect. It really goes in a lot of details of how we can prevent these long term. So if you haven't reviewed this statement, along with a lot of the data and research that have come out even after this, I think all of it really works well to help treat and prevent these cases. We talked about a second ago, other underlying things. Medical dissolution should always be your top option if possible. And I'll just emphasize if possible, because not all stones can be dissolved. If surgery is an option or if surgery is elected, please keep in mind that the gold standard here is to be as minimally invasive as possible. And naturally, we say that with any procedure we do, but specifically, I am emphasizing the type of procedure you do, because there are multiple approaches to surgically remove some of these stones that we may encounter in clinic. So first of all, with struvites, let's break down each one of these uroliths and how you can treat them. Well, good news with struvites, medical dissolution is typically going to be your go-to. There may be some caveats here, sometimes that you cannot medically dissolve these particular uroliths. The first one is going to be, hey, maybe the patient just won't eat the diet. You and I have encountered these in the past where we have a patient and it's not really an owner compliance issue. It's just maybe a palatability issue. The patient doesn't like it. So if the patient doesn't take the diet, well, unfortunately, we will not be able to resolve that stone likely with medical dissolution. Another contraindication is a bladder occupying stone. And this, for me, sometimes takes a hot minute to understand, but essentially, like I talked about a second ago, these diets work by bathing these uroliths in these pH modified urine. So if the bladder itself is taking up the entire, or sorry, if the urolith is taking up the entire lumen of the bladder, there's no room for these modified pH urines to work. The diet can't do what it needs to do, and in which case surgery may be indicated. And finally, in these patients with struvites, if you have this uncontrollable infection and these uroliths are the source of that in part, well, then surgery may be indicated. Nip that in the bud, remove those uroliths. When we talk about dietary options, there's a lot out there. And to be frank, this is not a exhaustive list, but many by Hills, Royal Canin, Purina, there are a few options out there. And like I said earlier, many of these are altering the composition of magnesium and phosphorus in those diets to basically help eliminate or limit, I should say, the intake for that patient itself. Not to be forgotten, all of these patients should have increased water content. How you do that is up to you. Maybe you're going to give wet food for this particular patient. Many of these diets offer a wet food version. Maybe you're adding water to their kibble. Maybe you're doing a water fountain. Whatever it takes to encourage them to drink, within reason, of course, should be considered. The nice thing about these diets is within weeks, you can see resolution of the uroliths, which I think is, to me, still fascinating that we have these large stones, in some cases very large stones, and all it takes is a diet, and you yourself can be the hero in those clients' eyes and to your patient because they didn't even need to have surgery at all. It tends to be the cheaper route, and you can save a lot of unnecessary pain and any recovery complications associated with surgery. Finally, don't forget, we mentioned before about struvite crystals and stones being associated with urinary tract infections. If that is present, make sure you treat and treat accordingly. I'll always encourage culture with MIC to make sure that you know exactly how to treat these particular bacteria and you're not just creating, say, a superbug, so to speak. Next up, we have treatment for calcium oxalates. Unfortunately, you do not see me start off this slide with medical dissolution. That's because with calcium oxalate, that's not going to be something that you're going to have available to you. Surgery is typically going to be your go-to with these patients. And when I say surgery, some non-dietary interventions. They may not all be typical surgery from the sense of involving an exploratory. A lot of us are comfortable with that classic, open abdominal cystotomy. But the point here to really hit home is that there are other procedures that do exist. Which method you choose is really dependent on the situation at hand. The first one, aside from cystotomy that I like to talk about, is voiding hydropropulsion. This is a non-surgical intervention, and essentially this technique uses gravity and manual expression of the bladder to non-surgically remove these uroliths. These patients are placed under sedation or anesthesia, likely anesthesia because you require an adequate plane to provide a lot of relaxation for these patients. What happens, or what we do, is we place a urinary catheter, we fill up this bladder, typically with sterile saline, we infuse it till it's moderately distended, and then essentially we're sitting these patients upright. So you're disconnecting them from your anesthetic circuit, you're sitting them upright, and then essentially you're manually voiding and expressing this bladder, and you're using pressures to help this patient urinate out the stones. As you can imagine, urethral obstructions are possible. We have to be very careful on the type of patients that we choose for this particular procedure. If the uroliths in this patient you've taken x-rays are huge, well, then you're not getting that out the patient via voiding hydropropulsion. You also have to be careful, especially in your male patients, that again, you do not induce this urethral obstruction as a result of trying to get these uroliths out. Next up, we have a procedure called a cystoscopy with basket retrieval. This essentially is a technique that uses a very small endoscope that we place retrograde through the lumen of the urethra into the bladder. And essentially, these endoscopes have a working channel. So you're able to place a instrument through this working channel, in this case, a stone basket. And once you place that tool in through that channel, that basket is able to expand. You can then grab onto the urolith and then pull it out through that channel through the endoscope. As you can imagine, though, these are for very, very, very small stones. If you have a case that, again, you have the option, you have these scopes, you can do for larger stones a percutaneous cystolithotomy. And essentially, this is an amalgamation, at least the way I see it, of a classic cystotomy, but also uses a cystoscope to minimize the invasiveness of the procedure, meaning you're making a much smaller incision into the abdominal cavity. You're then able to make a very small incision into the bladder, and you're using essentially a connector, a trocar, to link the gap between your external incision in the body and then your internal incision through the bladder itself. And you're using this scope to manually pull through these uroliths. So again, a procedure that you're going to be using for larger uroliths. The nice part about this, though, you're going to have decreased healing. You're going to have decreased recovery times. These patients are going to have, in theory, less complication rates. All of these procedures are, again, this is not an exhaustive list. There are other options like laser lithotripsy, which I won't get into a lot of details here. For our patients with upper urinary tract interventions, patients with these upper urinary tract uroliths, there are things like urethral stents, urethrotomy, and finally, the subcutaneous ureteral bypasses, or SUB. This is a device that essentially diverts urine from the kidney to the bladder. A catheter is placed into the kidney, a catheter is placed into the bladder. They both meet at a port under the skin. This can allow not only future monitoring for these patients, but also sampling, flushing, things of that nature. These are not something, though, that you are typically doing in practice. You may have the amenities available, you may have the expertise, but in my experience, these are typically patients that you are sending to, like I said, these referral hospitals, these specialty clinics for these particularly more invasive procedures. Next up, we have cysteine. So thank goodness we moved on from calcium oxalates. We have cysteines, which can benefit from medical management. Again, there are diets out there. Essentially, what they do is they alkalinize the pH of the urine. They also have modified protein levels. We talked before, protein being one of the basis for the formation of these particular uroliths. I also mentioned before about castration in some of these canine patients and that androgen response, and can we essentially slow down this cysteine accumulation in the urine by neutering them. We've talked about a few papers that suggest we can. There are some medications here that I have listed. Essentially, both of these medications, one improves solubility of the particular urolith. The other further alkalinizes the pH of the urine itself. I will emphasize here that typically these medications are given in addition to diet. It's typically not recommended to rely on medication alone for reasons that we'll talk about actually here in a second with our ammonium urates. But like I said, caution should be used. It's always, or many times mentioned, it should be given in conjunction with these dietary therapies. Speaking of other dietary therapies and other medical management, finally, we have our ammonium urates. Again, you're going to notice trends. Your cysteine diets and your ammonium urate diets may be one and the same, may be very similar. Treat the underlying issues. In some cases with portosystemic shunts, you're probably going to need to address that. Otherwise, these patients are likely going to have a more increased rate of predisposition long term, even after you remove those, or even after if surgical intervention is needed or medical dissolution is successful. One of the medications that I think of that come up from time to time with ammonium urate is allopurinol. This essentially is a xanthine oxidase inhibitor. It's going to reduce uric acid production, which in part sounds great, right? You think, well, hey, uric acid, Dr. Piccione mentioned before about how that being one of the building blocks for ammonium urate crystals. If we get rid of uric acid, eureka, the problem's solved. The dilemma with this is something always comes at a cost. So even if you are decreasing uric acid production, you are unfortunately having increases in xanthine levels. And xanthine levels can actually create xanthine uroliths, something we did not talk about in this particular lecture, but the emphasis here, similar to my last slide, is that xanthine oxidase inhibitors, or allopurinol in general, are typically given in conjunction with these diets, because these diets are what are really going to hold the key for these modified levels of whatever particular things that we're trying to limit. In this case, purine. Finally, here we talk about prevention. And I think that this is my, I won't say swan song, but this is how I want to end on a note with everyone here listening to this presentation today. Prevention, I think, is really going to be key. There is not one perfect way to go about doing this. I think it's an amalgamation of multiple things that you're going to see in practice. For one, that may include signalment and case history. If you have a patient or a breed that comes in that you say, wow, I've had a history of these patients in the past of developing uroliths, or I know that these patients are poster children for developing these uroliths, well, then maybe you want to have that conversation with that owner sooner rather than later. Needless to say, if you have a patient that has had a history of uroliths and they have been successfully treated, please make sure that your owners are aware that treatment does not mean that they will then be prevented for the rest of their life. They can still get these uroliths yet again. So preventative monitoring measures like urinalyses, even imaging, can be super crucial into preventing more headache down the road. Many of these patients that have been found to have uroliths benefit from lifelong diet management. There are some questions out there, especially with, we talked before about our cysteine patients and those being linked to various androgens. There has been some concern of whether or not if we neuter them, will they recur? I won't go there. I think the jury is still out on that particular verdict. But my point is most of these patients are going to benefit from lifelong diet modification. And then finally, if you have a patient with another underlying disease, maybe it's a portosystemic shunt, maybe they have this chronic issue of hypercalcemia of unknown cause, please make sure that you are educating your owners and making them aware that this may be a lifelong battle, and that when they see concerns of something like, ah, man, my dog's been going out more frequently, or my cat's been visiting the litter box a lot more frequently than I'm used to seeing, I'm having to change it more often, there may be a lot more merit to those concerns than meets the eye. So I highly encourage everybody, when you run into those situations, don't undermine the value of a diagnostic, or as I'll call maybe a therapeutic urinalysis or a therapeutic imaging, because in some cases, you may find something before it becomes a much larger problem. With that being said, there are a number of individuals that I do want to thank. Specifically, a lot of these photos that you see here today were made in part by Mr. Gwinner, Dr. Edwards, and Kelly, and our ClinPath department. I want to thank all of them, and even many more at TVMDL who not only helped support me with this presentation, but I think also mentally getting ready for this today. So I want to thank everybody here at the agency for making this possible. If you are interested in some of these papers, I do have the references for them listed here that I've talked about. A lot of great information provided and available to you, and even some great videos here that I reference as well. Last but not least, before we turn it over to questions, I do want to give a quick shout out. There are a lot of upcoming events that we mentioned that Mallory had talked about initially. I really encourage you all, if you're interested, please join us for these. A lot of great conversations from Dr. Schwartz, Dr. Hoskins, and Dr. Thompson coming up. So I really hope to see you all there. And without further ado, I have my contact information on here. If you guys do have any questions, please don't hesitate to reach out. Or, I'd say email is the best way to reach me. But without further ado, I will turn it over to anybody now for any questions that you may have, and I'll do my best to answer.
All right, Dr. Piccione, there's a few questions that's been submitted to the chat box. So the first one is regarding ammonium urate. The slide said Dalmatian fixed, English Bulldog not fixed. Were you saying this is observed more or less in these breeds regarding neuter status, or that due to genetics of each, so homozygous versus heterozygous, we should be fixing Dalmatians?
The short answer to that, I appreciate the question because I think it's a good call out. The short answer is neither. So when I use the term fixed versus non-fixed, so in Dalmatians, and again, I have to be very careful. I won't say every Dalmatian under the sun, but majority of your purebreds are going to be fixed for this genetic mutation, meaning if you see a Dalmatian, they likely have it. It is fixed that they have it. Non-fixed term inferring that these dogs may be a carrier, but it doesn't necessarily mean that carrier state is going to manifest in that patient. They may be, and that's kind of, I guess, your second point there. They may be heterozygous, meaning they're not homozygous recessive for that particular genetic concern. So if they are heterozygous or homozygous dominant, they may not manifest with any clinical signs. However, it may be an issue with them transmitting this disease or this genetic allele down to future progeny. So it's a great question, and I apologize for the lack of clarity there. But fixed meaning most of these Dalmatians are going to have it versus your other breeds and populations that just because they look like or they're commonly overrepresented doesn't necessarily mean they're going to have it. But if you see a purebred Dalmatian, it's got to be on your radar, and in my opinion anyway, and I do feel it needs to be a discussion with their clients for a preventative means long term. I don't want to stereotype Dalmatians and say every Dalmatian's going to have it, but I do think it should be a point of conversation sometime in their life.
All right, so the next question is, does FTIR work equally well on enterouroliths?
So the short answer is, in my experience, no. They can be done, and I have seen results on them, but I will tell you they are a different beast altogether. But we have received submissions from enteroliths. In fact, and there may be some on in this call right now, but we actually got an enterolith the other day from a whale shark, which I thought was completely fascinating. We have tested them, but I will tell you more times than not, the results may or may not be diagnostically beneficial because, again, much of the database that we're using is more geared towards these uroliths in particular. But I don't want to discourage you from sending them, and I will just go so far as to say, if you do have any questions additional to that, feel free to give me a call or give the lab a call, and we have an entire department that will be more than happy to help on that.
All right, so one more question in the chat is, FTIR in Texas the same method University of Minnesota uses?
It's a good question. The short answer is I believe they use FTIR in part. I can't comment on, diagnostic tools available for uroliths at University of Minnesota. I'm sure they have that listed there. I am confident that they use FTI in part. I do not know if that is the only method that they use at Minnesota. Good question, though.
All right, that's all the questions in the chat. If there's any more, you can submit those in the chat, or if you want, you can unmute yourself and ask that way too. Okay, I think that might be all the questions that we have. Thank you so much, Dr. Piccione, and thank you again for everyone joining us today.
Thanks, everybody. Appreciate you.